So you've been diagnosed with melanoma, and I think it's real important to understand some of the basic principles with melanoma. Melanoma is different than the other skin cancers, and melanoma is more dangerous. And surgery has a primary role in cure of melanoma. It needs to be taken seriously, and many times involves more surgery than you would expect. But having said that, it's all relatively superficial surgery, and it needs to be done in a timely fashion to effect a cure. Melanoma is a skin cancer associated with sun exposure. Probably 5 sunburns as a child put you at increased risk for melanoma. Caucasians, blue-eyed, blonde hair like me, we're at real high risk of melanoma. I've had a melanoma. Where you live makes a difference. People in California, Australia, Texas have a higher likelihood of melanoma. People in Seattle do too, because they get sunburned when the sun comes out. They go a little bit out of control. When you have a mole that is changing, it is a concerning mole and should be looked at. If you've got a diagnosis, you already have done that, but in terms of your family, always be aware that a mole that follows the ABCs of melanoma is something to be concerned about. A would be asymmetry. It's not just round, it's got an edge that's craggly, or it's changing in some way that it's not just a round pancake anymore. B is the border. The more irregular the border of the cancer, of the mole, the greater chance that it's cancerous. C is the color. Any color change is concerning. A mole can be very dark all your life, but if it suddenly changes to a different color, that is concerning. And melanoma isn't necessarily a dark mole. It can be red, it can be brown, it can even be whitish. So any change in the color of a mole is concerning. And then diameter. If a mole is the size of a dime, it's greater chance of degenerating into melanoma than a small little mole somewhere else. So keeping an eye on those is good. But E is evolution, and that is the mole is changing in some way. It's started to bleed. It's gotten change in its border. It's become itchy where it didn't used to be. Something that's evolving about that mole means it probably needs a biopsy to find out what it is. And once you have the diagnosis of melanoma, the next important question is the medical question of how much melanoma do you have? Is it spread through your body? Is it just there on the skin? Has it spread to the lymph nodes? And the medical word for that is staging. And one of the important roles of a surgeon is to cure the melanoma, but also to define the parameters and get you an answer as to what the stage of your cancer is. Because the stage of the cancer, the higher the number, the lower the chance of cure. But melanoma is weird that way. If you had pancreas cancer and stage 4 pancreas cancer, there's almost nothing that can be done to save you, despite all the heroics that we can do in medicine. But with melanoma stage 4, if it's in your brain and bones right now, there's a 5% chance that you're going to be alive and free of cancer 15 years from now. So there's something about melanoma that's unpredictable, both in a bad way and in a good way. And we think it has to do with your body's immune system waking up and recognizing it there. Whether those patients are there because of the power of prayer, or their immune system, or the right diet, or whatever, they have a chance of living long term even with stage 4 melanoma today. Most people in America are getting them looked at relatively early and are in an early stage with their melanoma. So let's talk a little bit more about staging. If you've got a mole on your skin, it's sitting on top of skin that's thicker than the mole, and underneath that there's a layer of fat, and underneath that there's a layer of muscle. And melanoma is primarily staged on the depth of invasion into the skin. Melanomas can develop into little towers. Melanomas can dig in. Melanomas can set down potato-type roots where it spreads locally or within the skin around it, or it can set down almost a carrot-like root down underneath there. And so the biopsy that's done on the surface may not give you a full appreciation of how deep the cancer is. And that's one of the roles of the surgery. With melanoma, we do a wide excision when it's melanoma. If you have a basal cell cancer in the past, they chunked out a little bit around it. With melanoma, we generally need to go 1 centimeter to 2 centimeters of skin around it, which is almost an inch. And we need to go all the way down to the muscle down below to take out all of that so that can get sliced and diced and looked at into the microscope to find out if the depth of invasion is greater than thought or whether it looks like it's spreading superficially in the immediate area. All of those factors tie in with whether the cancer is behaving aggressively, whether your immune system is fighting it aggressively, and ultimately whether that affects your survival. So part of the melanoma process is the first surgery to just get a biopsy, which is pretty minor, and the next operation is taking out a bigger chunk of skin. The other part about staging is whether the cancer has spread to your lymph nodes. And if the melanoma depth is greater than 0.8 millimeters, there's a chance that that cancer has spread elsewhere through the body through the lymphatic channels. And if you've ever seen somebody with what they call blood poisoning, where there's a red streak going up the arm from an infection, that little red streak is in a lymphatic channel. And it spreads infections throughout the body, but it also can spread cancers throughout the body. So when we're dealing with melanoma, we want to know where that cancer could go to next. And we call that the sentinel lymph node. The sentinel being the guardian at the gate. And you have lymph nodes throughout your body. This part of your skin and that part of your skin probably drain to a different lymph node. So being able to find that lymph node and accurately to define whether there's cancer in it or not can make a big difference. If the cancer's gone to the lymph node, it's stage 3. If it's not gone to the lymph node, it's generally stage 1 or 2, and that makes a big difference in your likelihood for survival and in how aggressive we need to be treating your cancer. So the day that all of this is cut out, we need this tissue to tell us where the sentinel lymph node is. So the day of surgery, this area is injected with radioactive material. And that radioactive material percolates through the lymphatic system and accumulates into the sentinel node. That sentinel lymph node will then be radioactive. And during the operation, we can use a sterilized Geiger counter and find that lymph node. Sometimes it's 2 or 3 lymph nodes. But wherever that cancer goes, we want to follow it and head it off at the pass and find out if it's already beat us to the pass or not, and take those lymph nodes out. So if your cancer, say, is on your arm, frequently those lymph nodes will be in your armpit. If the cancer is on your head, it can be in your neck. If it's on your leg, it can be in your groin. And for the patients who have cancers on their trunk, it can be in the groin and in the armpit. So this requires a scan, a radioactive scan, the day of surgery, before surgery, to define where that radioactive is. And then during the operation, those lymph nodes are sought out. That's called a sentinel lymph node biopsy. And those get looked at, sliced and diced at under the microscope also, not during the operation, but later on, so that 4 or 5 days after the operation, we get a final pathology report that tells us about depth of invasion, whether it's spreading locally or not, and whether it's spread to the cancer in the lymph nodes. So stage 1 and stage 2 melanoma are generally about the depth of invasion only. Stage 3 melanoma is there because the cancer has spread to the lymph nodes. And stage 4 melanoma would be cancer that is spread beyond the lymph nodes to the bone, the brains, the blood, the bladder, the bone marrow. Any place in the body is a potential spot for melanoma to spread to. So the surgery has a critical pathway up front in finding out how much cancer you have, defining the staging. If you have stage 1 or 2 melanoma, frequently you'll just need to have ongoing surveillance of your skin by a dermatologist who's trained to look for other skin cancers, because your greatest chance of another cancer after melanoma is another skin cancer, not necessarily melanoma. It's all about the sunburn. But certainly another melanoma could come up. If, on the other hand, cancer's in the lymph nodes or deeply within the underlying fat there, then there's a role for a different form of therapy. And this gets back to those 5% who were cured despite the fact that they had distant melanoma. And that is a role for immune therapy, which is a rapidly advancing field as a subset of oncology. So if the cancer is a deep level 2 or level 3 or level 4, you'll be sent to an oncologist, and the oncologist will advise various forms of immune therapy to treat the melanoma and get it to regress. And there are patients with stage 4 melanoma that really need that therapy and will have it disappear. And there are others that won't respond well, but that's part of the oncology world. And if you have that stage cancer, they'll have an extensive conversation with you about how that affects you, what your prognosis is, and where you're going to go with that. So hopefully you're not going to get to that point, but that would be the next jumping point after surgery if you have to have a deeper stage melanoma. So with melanoma surgery, the surgeon needs to get an adequate margin around the cancer, get deeply around the cancer, and also find the sentinel lymph node. So you need to understand how much of an impact that's going to have on your body. And if that's on your forehead, it's a bigger impact cosmetically than if it's on your trunk or on your arm. But in either case, it may be more than you're expecting, but at the same time, it's not an internal organ. It's a superficial operation. This is usually done as an outpatient because we're not doing a lot to your deep internal organs. The bleeding risk is low. The pain level is usually manageable. And it's a good operation to have done, but it will occupy most of your day. The day of surgery, you will begin in the hospital setting getting a radioactive injection at your site of cancer. And you can expect to be there 2 to 3 hours as that radioactivity migrates through your system and accumulates in your lymph nodes, either in your armpit or your groin usually. And then they can tell us how many lymph nodes are radioactive and where they're radioactive, so that guides us during the operation. After your hospital phase, you go to Meridian Surgery Center, and at the center, you'll have an IV started. You'll meet the anesthesia provider, and you'll be there generally 4 to 5 hours before you go back home. With the operation, you'll get 2 things done. You'll have the cancer taken out, and you'll have the lymph nodes sampled to find out what's in the sentinel lymph nodes. But the operation itself at the site of the cancer will involve taking out the cancer. So if your melanoma scar is about that big from where they did the biopsy, I'll be measuring either 1 centimeter or 2 centimeters out in all directions around that site. And all of that will need to be taken out. And that will be taken out all the way down to the underlying muscle. So if you're a chubby person, that can leave a pretty big divot there. If it's on your arm, you may have some thin skin there and it's not that deep. But all of that skin needs to be taken out. And then I've got a hole that I've got to deal with, and I'd like to sew you back together again. One approach for this is to leave that hole and later do a skin graft after there's an adequate amount of healing there to accept a skin graft. That requires a couple of operations, and I prefer to do everything with a little plastic surgery rearrangement at the time that the cancer is taken out to minimize the potential for needing to come back and all the wound dressing changes that go along with an open wound and a skin graft. A skin graft process sometimes is necessary if there's not adequate skin to close it up, but it is a process that takes a couple of months before the healing is completed. Usually, we're going to rearrange the skin. So if I'm taking this much out, I may also take out some extra skin surrounding that and allow me to move skin from point A to point B across the defect. So I'm creating a flap from this area here where the skin is more lax, where you have extra skin, and move it across so that you end up with a curved suture, a suture line, where point A and point B are brought together with a flap of skin being moved across, and that means that this is under more tension than it used to be. And that tension means that these stitches need to be in there for 3 weeks or a month. As you grow more skin and as the tissues realign the way they want to stretch around that area. So when this is done, if it's your arm, you'll feel that it's pretty tight there. If it's your belly, you'll feel that it's tight there also. And as that tightness sensation goes away, you're changing the elasticity of the skin over 10 days. You're growing more skin by 3 weeks. And it's taking the tension off of those stitches so we can later on take those stitches out. But you can heal without having an open hole and a skin graft involved. So that's a flap advancement closure. Those stitches there will dig into you because it's under tension. If you have a friend next door that says they're really good at taking out stitches, and they look at that and they say, oh, those stitches are digging into you. You need to have those stitches out. I can take those stitches out. I'm really good at that. Do not say yes. I had a lady that came all the way over from Yakima to have a big operation. She had a long incision. We were doing this with her, and her neighbor took her stitches out a week after surgery, and her wound popped open, and she spent the next 3 months coming back and forth, back and forth, back and forth from Yakima for us to take care of that wound eventually into a skin graft. So don't be in that group. These stitches will dig into you. There will be a railroad tracking there. It is going to be a big scar when it's all done with. But it will heal primarily with normal skin surrounding it without a skin graft involved. So this part of the operation usually takes an hour, hour and a half. The other part of the operation is finding the sentinel lymph node. And with the sentinel lymph node part, say it's in your armpit. So I'm a terrible artist, but if this is your arm, this is your armpit area, you'll have an area there that's emitting radioactivity, and we'll make an incision where that radioactivity is and go in and take out the radioactive node. If there's a couple of radioactive nodes, then we'll take them out. And anything that's radioactive is radioactive because the radioactivity was injected down here where your cancer is. It is spread to there. That's where the cancer wants to spread to. And our goal is to take those nodes out and find out if there's cancer there. One common point of misconception is that I found a sentinel lymph node and therefore there's cancer there. That's not correct. If I found the sentinel lymph node, I found where the cancer is going to next, and I've sampled it to take it out, to stop the progression and to provide adequate staging and to know for sure whether there's cancer there or not. So that operation usually entails an incision either in the armpit or your groin. Usually it's someplace where your body's bending, where the lymph nodes accumulate. And that part of the operation can take a couple of hours or an hour and a half. Sometimes it's just an hour. Depends on how deep there are and how many lymph nodes there are. This area is more prone to infections than your arm or your leg where the cancer originally came from. So there's some greater chance for wound infection there. The day of surgery, you'll get some antibiotics to minimize that, and you'll sometimes have a drain tube there where the lymph nodes came out if we took out a lot of lymph nodes. But generally, this incision will be sewn shut with stitches underneath the skin. It won't have the tension issues where the cancer came out from. Usually it's 4 days after the operation before we know what the pathology report shows and get all of the staging information. At that point, we start deciding whether we need oncologists involved or PET scans or anything, or whether it's just a matter of getting back to your dermatologist for further treatment. The preparation for surgery usually involves getting a few blood tests and a chest x-ray just as a screening to make sure that the cancer hasn't spread elsewhere. There are a few blood tests that are specific to this. If the cancer has spread elsewhere, then we get bigger scans like PET scans, CAT scans, brain scans, MRIs, that kind of thing, looking elsewhere for where the cancer may have spread to. So hopefully, and generally speaking, most people with melanoma in America don't go on to that next phase, that next level of care. The day of surgery, I mentioned, is a long day. Don't want to be eating or drinking anything the morning of surgery. You'll be in the surgery center usually 4 to 5 hours, but that night you should be up and around the house in your own home and ready to take on many normal activities. Because of the site of the surgery, there may be limitations on what you can do with your extremities or how long you should be in water, but generally speaking, you can shower the next day, but you shouldn't be soaking any of these incisions in a hot tub or a swimming exercise or anything like that for a number of weeks after surgery. Sometimes, because things are in a bend, you'll end up with some tightness there, and once the healing is done, the stitches are out, we'll send you to physical therapy to work on joints and stuff to get full range of motion, particularly if it's in your hand area, to get that skin stretched out actively and return all normal function. So melanoma is an important cancer that needs to be dealt with from a surgical standpoint to affect cure and to affect accurate staging. And we're happy to be able to do that. Many times this is very easily accomplished at Meridian Surgery Center. Okay, now I've got a really unpopular subject, and that is complications after surgery. All surgeries have potential complications. Some surgeries have different complications from others, but there are some that need to be watched out with every operation. One of those are things that people naturally are afraid of, and that's bleeding. For most operations, the risk of bleeding is relatively low, amounts to bruising, and rarely results in transfusion. If you have religious objections to blood products, be sure and let your surgeon know about that. But rarely do we need to proceed on with any bleeding, transfusion sort of issues in general surgery and the stuff that I'm generally doing. But there are a few things that can increase your risk of bleeding that you need to be aware of. Aspirin increases bleeding, it increases bruising substantially, and unless your doctor feels like you need to be on aspirin despite the fact that you're having surgery, most patients will be taken off of aspirin. Likewise, ibuprofen, Aleve, any of the non-steroidal anti-inflammatories also have the same effect on clotting. So we'll generally have people off of those medications for a few days before surgery. External bleeding is very obvious. If you've got a spot of blood this big on your dressing, it's probably going to stop on its own. If your dressing, however, is soaked and looks like it's continuing, you need to notify your surgeon right away. Frequently, that will get better just by applying pressure. But if it doesn't, it will need to be addressed during a close time frame there. Don't be polite to your surgeon. I like that if you are, but don't wait till morning if you've been bleeding all night. That can be a real problem. And let the surgeon know if you're soaking your dressings. The other way that you know you have bleeding is something you might not think of up front. For most operations, we want you up and around the house the night of surgery. And walking is good. It prevents blood clots. It keeps you mobile. But it also gives us an early warning sign. If you're attempting to walk the night of surgery and you're pale and you're passing out, that's either a heart problem or that's internal bleeding. That's an automatic trip to the emergency room, and nobody should talk you into going to bed because you're dehydrated, you just need to rest. If you're pale and passing out, or just passing out period, when you try and walk, that's internal bleeding and needs to be evaluated that night. Call 911, call me on the way. Infections are also a risk with surgery, and anytime the intestines are cut across, there's a higher risk of infection. Wound infections are not common at Meridian Surgery Center. The risk is about 1%. If your wound is red and angry, if it's draining pussy stuff, if you're having a fever over 101, those infections symptoms are generally going to occur in the first week to 3 weeks after surgery. It's a nuisance. It might scare you, but it's probably not an emergency that requires an emergency room visit. And if you go to the emergency room, you're going to be there 10 hours. Calling the surgeon, texting a picture is the better way to do it, way faster, way cheaper, and will save you a lot of trouble. I had a patient 2 years ago who was pacing in the emergency room with this problem. He'd been there 4.5 hours. He was getting really mad. Other people were going ahead of him. He wasn't getting any attention. And he just went, I'm supposed to be calling Dr. Wright. What am I doing here? And we had it all figured out for him within 15 minutes. So be aware, the emergency room isn't generally the place for that kind of a problem. Let's get it taken care of. Anesthesia-wise, your operation generally involves anesthesia. Local anesthetic has very minimal risks, but if you're allergic to lidocaine or bupivacaine in the dental office, we need to know that because that's what we're generally using, something related to that. General anesthetic and sedation procedures have risk of anesthesia as well. We're generally evaluating that in the clinic as we go along with the surgery evaluation, and patients with high risk are generally done in the hospital setting. Patients with intermediate risks and low risks are in this outpatient setting. But that's part of why we're doing blood tests and EKGs in evaluation before surgery. And sometimes you'll be set up for an outpatient surgery, and those tests will either cancel the surgery and require a cardiac evaluation, or change the setting of the surgery, or tell us something else needs to be done before the operation is done. But we deal with, in the outpatient setting, minimizing the anesthetic risk and getting you through the operation as smooth as possible. You'll be speaking with the anesthesia provider specifically about your situation the day of surgery before you go in for surgery. If you have sleep apnea at baseline, we do ask you to bring in your CPAP mask because that can be helpful in the recovery phase when you're not breathing so well and when you're not as awake, sort of like it helps you at night. Medications that we give after surgery can have reactions too, particularly if you've never seen them before. If you've had problems with certain pain pills before, we need to know that up front so that we don't get you into the same trouble that you had before. But generally, narcotic pain medications are constipating. And the number one distress call I get is usually 4 days after surgery. Somebody hasn't thought about how their bowels are working. They've had their surgery, they're doing okay, but now they can't poop. And it can be the most miserable part of your operation if you're bloated after an abdominal surgery and you can't poop and you have to push it out, and nobody wants to give you an enema. So you need to be proactive on that. So the night of surgery, drink plenty of liquids. When you're starting to eat, don't jump into meat and potatoes. Instead, fruit and vegetables. You want lots of fiber in your diet that will help you with your bowels in that immediate postoperative period. And if you're a constipated person in the first place, clean out before surgery, take laxatives, and keep your bowels working. You would rather have the trots in 2 days than bricks in 4. But certainly keep an eye on it. If you normally have really good bowels, you don't even have to think about it, be thinking about it. If you haven't had a bowel movement in 2 days, you need to take a laxative and get things going and make sure that you don't get bound up. That's the best way to have a smooth operation after the operation. So when it comes to complications, nobody can tell you all the possible complications. There are a number of things that can go wrong. Your informed consent forms will give you a lot of answers there. But generally speaking, the more experienced your surgeon is, the less complications you're going to have because they've seen things before, and that experience helps them keep their patients safe. So at Meridian Surgery Center, you'll see a lot of experienced surgeons and providers at your bedside, guiding you through your operation to minimize your potential for infection.